So I'm going to introduce Dr. Peter Holoch. It's a pleasure to introduce him. We are so happy to have him back. Peter is a native Vermonter. He went to medical school right here on this campus, then went out to University of Iowa for urology residency and a special fellowship in andrology, men's health. And so he's the perfect person for this. Peter also has another distinction. He is an expert in reconstruction of the urinary system after trauma or cancer. And we're very happy he is here back in Vermont. Dr. Holoch.
I want to thank the Vermont Cancer Center for the opportunity to talk to you today about male hormones and aging. And thanks to Mr. Brooks for organization. So I'd like to start out with some hormones that we know change as men get older that we're not going to talk about. And the reason we're not going to talk about these things is we don't know what clinical effect, if any, the decline in these hormones have on men. And we also don't know what the effect is on replacing these hormones. We just don't know much about them, except that they do decline as men get older. And that's DHEA, melatonin, growth hormone, and insulin-like growth factor 1. Melatonin you've probably heard about as a hormone involved in cycles like sleep cycle. But studies looking at its replacement have shown mixed results, and I don't think we really fully understand it at this point. The main male hormone is testosterone, which will be the focus of my discussion today. Testosterone is involved in the development of the embryo into a male. It drives male puberty, and it has many important functions in the male body, notably preserving muscle strength, bone strength. It has effects on skin, on blood production, and of course, it has effects on sexual function, and in the younger male is critical for sperm production. Testosterone can be converted to dihydrotestosterone. Scott just told you about how that step is what is blocked by the medications finasteride and dutasteride. Dihydrotestosterone, or DHT, has effects in specific organs, especially the prostate, where it can drive prostate cell growth, but also is related to male pattern balding, which is why finasteride can be used to treat that condition under a different name, propecia. Testosterone can also be converted to estradiol, or estrogen, in the man's body. In fact, most of our estrogen comes from testosterone that's been converted to estrogen. And we'll talk about that more in a little bit. This is a picture of three, you kind of missed the top one here, but 3 areas in a man's body responsible primarily for testosterone production. And that is the hypothalamus, which is an area in the brain, which communicates with the pituitary gland, which is a small gland that sits just beneath the base of the brain. And down here we have the testicle, which produces testosterone. About 90% of testosterone, maybe more. The other 10% comes from the adrenal glands, which are small glands located above each kidney, one on each side. The hypothalamus releases gonadotropin-releasing hormone, GnRH, as a signal to the pituitary gland. The pituitary, in response to this, releases luteinizing hormone, LH, which travels to the testicle and tells the testicle to make testosterone. The cells within the testicle that produce testosterone are Leydig cells. They're separate from the cells that produce sperm, but they all live together in the testicle. Testosterone is then released into the bloodstream, and it goes back to the pituitary, and it goes back to the hypothalamus and says, we have enough testosterone, we don't need any more. We don't need any more LH to be released, and the process slows down. If testosterone levels drop, there's less of that stop signal, and more luteinizing hormone is released, and more testosterone is produced. And that's how the body keeps testosterone levels within the, quote, normal range. So any disruption in this process can lead to a problem with testosterone production. Testosterone, once it's released into the bloodstream, travels in different forms. Most of it gets stuck to other proteins in the bloodstream, notably sex hormone binding globulin, or SHBG, which sticks to testosterone so tightly that that testosterone is pretty much useless. It has no effect on the tissues elsewhere in the body. About 38% is stuck to other proteins, like albumin, that don't stick quite as tightly, and so the testosterone can kind of go back and forth. And then about 2%, or maybe a little bit less, is just free-floating testosterone in the bloodstream, which is obviously exerting its biologic effect. So if we look at those two together, the albumin and the free testosterone, we call that the bioavailable testosterone. That's testosterone that can actually have an effect on our tissues and our brains. So here's a little diagram of testosterone stuck to sex hormone binding globulin. This cannot have any effect on the cell here. Here's a cell. Testosterone inside the cell will bind to a receptor molecule. And then the testosterone accompanied by its chaperone receptor will go into the middle part of the cell, the central part called the nucleus, where our DNA is. And as a result of that, certain genes in our DNA get turned on, and this is what results in changes from testosterone. So you may have heard this term male menopause, or andropause it's called sometimes. And this is a relatively new concept. We know that women experience a dramatic drop in hormone levels as their fertility ends. But in men, testosterone drops very gradually. There's no sudden drop-off. On average, it drops about 1% per year after the age of 40. But it's important to know that that's an average. And in some men, the testosterone may remain the same for a long period of time. In others, it may drop more quickly. It's also important to know that testosterone levels are very different in different men. You could have two very healthy 20-year-old men with very different testosterone levels and no problem from that. The other thing that's important is that in young men, testosterone levels tend to vary quite a bit throughout the day. So if you check someone's testosterone in the early morning around 8 o'clock, the testosterone level will generally be quite a bit higher than it is towards the end of the afternoon. And so every day, the testosterone is cycling up and down by quite a bit, maybe 20%. However, in older men, that cycle tends to be much less pronounced. The rises and falls are less. And so instead of big changes in testosterone throughout the day, there are only very, very slight changes. So who cares, right? There's a common misconception out there that testosterone is the fountain of youth. You replace my testosterone, I'm going to be young again. And that is simply not true. I don't think this is even working. So what is the effect? Is declining testosterone as men get older, is that a normal process? Is that just inevitable? It happens. Does it happen for a reason? And do we need to worry about it? Is low testosterone in an aging male a disease? Is this something that we need to treat? And I think these questions are open for debate. I don't think we know the answer to this. But the pharmaceutical industry has really been driving Testosterone Replacement has been making a lot of money from this, and rates of testosterone replacement have gone up dramatically over the last decade. So to try to answer some of these questions, I'd like to look at men in whom testosterone drops for reasons other than aging. Some men will experience trauma to the testicles, and this can result in a profound loss of testosterone production. Some men have testicular cancer, as Dr. Parapato spoke about earlier, and if they lose both testicles, they will also have a very dramatic drop in testosterone levels. Sometimes the testicle can twist around its own blood supply, cutting off its blood supply, and it will die and will not produce enough testosterone. Pituitary diseases, remember the pituitary gland that produces luteinizing hormone, can also cause problems with testosterone because if you don't have luteinizing hormone, you're not going to make enough testosterone. Surgery on the pituitary, injury to the brain, these things can all cause very low testosterone levels. There are certain genetic problems that lead to problems with testosterone production, notably something called Klinefelter syndrome, in which a man has an extra X chromosome. So instead of one X and one Y, the man will have two X chromosomes and a Y in most or all of his cells. And this leads to very, very high luteinizing hormone levels, but only very low testosterone levels because the testicles, the Leydig cells, are not functioning normally. Finally, there are certain drugs that can certainly cause problems with testosterone production. And unfortunately, we are living with the reality of the opioid crisis. Is that what it's called in the news, the opioid crisis? A lot of young men are using opioid pain medications chronically or recovering from an opioid addiction and taking medications like methadone or Suboxone, which are still opioids. And these medications have a profound effect on the hypothalamus and pituitary, and these men oftentimes have very low testosterone levels. I also listed anabolic steroids. Well, when I think anabolic steroid, I think testosterone. Why would testosterone lead to testosterone deficiency? Well, the answer is when a man takes testosterone, especially at very high levels for a long period of time, that's shutting off that luteinizing hormone signal that goes to the testicle. The body thinks it's got plenty of testosterone, it doesn't need any more, and it shuts off the pituitary signal to the testicle. And if that state is sustained for a long period of time, some men never recover and will never produce natural testosterone again. And they will end up with very low testosterone levels if they stop replacement. And finally, treatment for prostate cancer sometimes involves dropping testosterone levels dramatically, either with medications or surgery to remove the testicles, because prostate cancer requires testosterone for its growth, as I think Scott alluded to earlier. Looking at men who are treated for prostate cancer with medication or surgery and who experience very, very low testosterone levels, these are some common symptoms these men develop. Sexual dysfunction is very common. Fatigue, hot flashes, just like a woman going through menopause. Men with very, very low testosterone levels will experience hot flashes. They may experience osteoporosis and bone fractures because of the effect of estrogen on bones, and most of our estrogen comes from testosterone. So if you lose that estrogen very quickly, you may become more susceptible to loss of bone strength, loss of muscle mass, gain of body fat. And these men are more susceptible to developing blood clots, diabetes, heart disease. Diabetes and heart disease should ring a bell. Dr. Parabato was talking about metabolic syndrome, and we'll get back to that in a minute. So to try to, we're trying to define what testosterone deficiency is, because right now nobody really agrees on what this means. There's no definite definition, if you will. So the currently accepted definition in urology, at least, and also in endocrinology, is blood testosterone levels below normal and symptoms of a low testosterone. Now, the problem with this is nobody agrees what normal is. Different laboratories have different reference ranges for testosterone, even though they're using the exact same test. So because of this, and also because different studies have looked at different numbers or types of symptoms, we don't really know who has testosterone deficiency and who doesn't. So if you look at 3 specific symptoms and a testosterone level below 220, as a large study in Europe did, you'll find about 2% of men have testosterone deficiency. But if you are just looking at the numbers, just the testosterone level, and you use 300 as a cutoff, then up to 40% of men over the age of 40 have testosterone deficiency. So what are the symptoms that men might experience? This would be aging men whose testosterone has been gradually declining, as opposed to someone who has had a sudden withdrawal of testosterone for cancer. Low libido is the most common symptom that I see. But the most common reason men come to see the doctor is not low libido. It's erectile dysfunction. Erectile dysfunction is tricky, especially as men get older. There are so many things that can cause erectile dysfunction that it's frequently not only due to low testosterone. But because it's involved to some extent, it brings a lot of men to come see the doctor. Difficulty achieving orgasm, decreased sensation, these things can be related to low testosterone. Low energy, fatigue, are also very common symptoms of low testosterone. But lots of things can cause low energy and fatigue. These are not very specific for low testosterone. Irritability, mood changes, low motivation, and perhaps impaired cognition can also be associated with low testosterone. And finally, the things we've talked about already with decreased muscle mass, increased fat weight, and decreased bone density, all of these things are related to low testosterone. These things generally occur at much lower testosterone levels than these 2 columns. These occur relatively early. One important associated condition with low testosterone is sleep apnea. Sleep apnea, we've come to recognize in the last decade, can have a lot of very serious health effects, including cardiovascular risk. And so sleep apnea, if identified in the workup for low testosterone, should absolutely be treated. But it is associated with low testosterone. And whether sleep apnea causes low testosterone or low testosterone causes sleep apnea, we don't know. The same goes for the metabolic syndrome. Metabolic syndrome is high triglycerides, low HDL, which is the good cholesterol, visceral or central obesity, so the apple shape with a lot of weight around the midsection, high blood pressure, and resistance to insulin. Insulin is the hormone that drives sugar into the cells. And as this progresses, it becomes diabetes. Those are the components of the metabolic syndrome, and these things are all associated with low testosterone. At least 50% of men with metabolic syndrome will have low testosterone levels. And the relationship between the two is also not fully understood. So the treatment is the same as the things we discussed for preventing prostate cancer or other cancers, and the same thing that we've been hearing for decades, which is exercise and a healthy diet. because these are the things that prevent the development of metabolic syndrome. And the rate of metabolic syndrome has been climbing over the last several decades, probably related to changes in our diet and activity level as a population. But sometimes these things are not enough. So at some point, we may consider testosterone replacement. If the symptoms are bothersome enough, if blood levels of testosterone are clearly low. So the first question that comes up is testosterone replacement, or taking testosterone as a drug to treat those symptoms, is this safe? Although there's been a lot in the media about an association with cardiovascular disease, the studies that were done that pointed to this possible link were not done to look for that, and were rather poorly designed. And so there really is no clear evidence of an association with cardiovascular disease, nor is there a plausible mechanism, except for one that we'll discuss in a minute. And so there's ongoing research looking at this, but it doesn't appear that there's an increased risk of cardiovascular disease. There is an increased risk of cardiovascular disease, remember, in men who are treated with medication to lower their testosterone. There is also, to date, no evidence of an increased risk of prostate cancer developing as a result of testosterone replacement. And this is probably because prostate cancer cells don't need much testosterone to grow. Their testosterone receptors are saturated. They're completely full of testosterone at relatively low testosterone levels. And anything above that is not going to make any difference in the biology of the disease. And all the evidence we have so far looking at men on testosterone replacement show no increased risk of prostate cancer developing. There is a risk of erythrocytosis, which means too many red blood cells in the bloodstream. This can occur sometimes with testosterone replacement. Remember, not having enough testosterone can sometimes lead to anemia, which is not having enough red blood cells. Testosterone replacement in a minority of men can lead to too many red blood cells. And this can cause problems, potentially blood clots, potentially heart disease, stroke. And so that is a concern. Does testosterone replacement work? Does taking testosterone help with the symptoms we described earlier associated with low testosterone? There is a set of 7 trials being conducted currently to look at this issue, each one looking at sort of a different aspect of testosterone replacement. They are well-designed, randomized trials in which men get testosterone via gel or a placebo and seeing if there's improvement in symptoms. They looked at 790 men aged 65 and older with a testosterone level below 275. That was their definition of low testosterone. Our laboratory here says 241 is the lower limit of normal. Where that number comes from, I don't really know. These men who got testosterone replacement experienced improved sexual function on standardized questionnaires as compared to the men who got placebo. They had some improvement in physical function, and they had some improvement in mood and depressive symptoms, but not as dramatic as the improvement in sexual function. In the data that we have published so far from these trials, and remember they are ongoing, they found no increased cardiovascular risk. But the 3 trials that I told you about here were not designed to look for a difference. So they probably only would have picked up a difference if it was a fairly large risk. There is another one of these 7 trials, which is called the cardiovascular trial, in which men getting testosterone versus placebo are also getting CAT scans to look at atherosclerosis in the coronary vessels to see if there is a difference over time with testosterone replacement versus placebo. So we're looking forward to the results of that study. So the question of whether testosterone replacement might be helpful needs to be made on an individual basis with your physician. And the side effects of testosterone replacement need to be discussed in detail. Specifically, too many red blood cells developing, and we need to have a plan in place to monitor that, which is a simple blood test periodically to make sure that that red blood cell level isn't climbing too high. Other side effects, infertility, and we talked a little bit about why that is, because the pituitary signals to the testicle are shut off during testosterone replacement, and that shuts off sperm production. Gynecomastia means growth of breast tissue. And I don't mean just carrying a little extra weight here. I mean breast tissue actually can grow as a result of some of that testosterone being converted to estrogen. Sleep apnea may be worsened with testosterone replacement, which is another reason it's so important to treat this first if sleep apnea is present with a low testosterone. And then acne can also be a problem, but it's rarely a bothersome issue. The key is regular monitoring to make sure the testosterone level is in the safe range and to make sure the hematocrit is in the safe range, which is the amount of red blood cells in the bloodstream. We also monitor PSA, prostate-specific antigen. Although there's no evidence of an increased risk of prostate cancer, because of the theoretical risk, we still check that regularly. And also, a lot of men who are experiencing these symptoms as a result of aging fall into that category where screening for prostate cancer would be beneficial. And so it's good practice. Thank you.
The Atkins diet addresses the problem of metabolic syndrome. Does that affect the problems with the testosterone level?
I'm not aware of a study looking at that, but that would be a really good one to look at. The Atkins diet, you're referring to a high protein, low carbohydrate diet?
Yes, high fat also.
And high fat, yep. I don't know the answer to that. I don't know that that's been looked at specifically. But if that Atkins diet results in significant weight loss, then I wouldn't be surprised if there's some improvement in testosterone levels.
Do some of the other classes of steroids interact with testosterone? Statins, for example, controlling cholesterol, simvastatin.
So simvastatin is not a steroid. Cholesterol is the precursor molecule from which testosterone is made. They're closely related. Statin use doesn't appear to affect testosterone levels that I'm aware of to any significant or clinically significant degree. No. I'm not aware of any foods that will cause your testosterone levels to rise or to drop. There are some foods that are thought to maybe modify estrogen levels a little bit, like soy in very large quantities. But I don't think that's really not often clinically significant. Scott. My preferred replacement? No, I didn't get into the specifics of pharmacotherapy, but so there are different ways of replacing testosterone. In Europe, there is a second-generation oral form of testosterone available, which is not available in the US. The first generation of oral testosterone was dangerous because everything that you eat goes through your liver, and it caused some liver problems. That doesn't appear to be the case with the second generation. However, there are wide variations in how well that's absorbed, and that's why the FDA has not approved that in the United States. So what we have available are things that go through the skin, either gels or a patch. We have a buccal preparation that goes in between the gum and the cheek. I'll tell you right now that I've had no success with that. All of my patients who have tried that have been very annoyed by it. You have to replace it twice a day. It leaves this residue. It's available, but it's not used very often. And then finally, there are injections that can be done into the muscle every 1 to 3 weeks, depending on what dosage is required. There is some evidence that some of these side effects, particularly the increased production of red blood cells, may be a little bit worse with the injections than it is with the transdermal preparations. The injections are cheaper, so if insurance companies get upset about one of the transdermal methods, they will often prefer the injections. The absorption I find much more reliable with injections, obviously, than things going through the skin. That can vary tremendously from patient to patient. I have some patients that I'm unable to get their testosterone into the normal range with any type of gel or patch. The medications through the skin provide more steady levels of testosterone throughout the day, whereas injections result in big spikes and valleys. So the testosterone level may go actually too high right after an injection, and then it may fall down and be a little bit too low before the next injection. And for some men, that is very unpleasant because they will really feel that low testosterone level, and they'll have a recurrence of their symptoms every 2 weeks of fatigue and lethargy and decreased interest in sex and that type of thing. So those are the differences. And then there's another option, which is little pellets that are placed under the skin that slowly dissolve over 3 to 6 months. The problem with that is you can't take them out. You can, but it's not easy. So I never start my patients off with that option until I know what dosage they're going to require, and until I know that they're not having a problem with their hematocrit going too high, too many red blood cells, or the prostate-specific antigen level going up to suggest need for a biopsy. But once things have been stable for a few months, then that becomes another option. And that is actually becoming one of my preferred options, although I leave the decision up to my patients. But it's very convenient, and you don't have to be getting injections every couple weeks or rubbing gels on every day. And the risk with that's specific to those pellets is that on rare occasions, a man's body may just reject it and have a reaction to it and actually extrude the pellets eventually. That does not happen very often, but that's a potential risk. Good question, Scott. Yes, sir. What questions should you ask me before I leave? Okay. So the fountain of youth, I think, is something that's, maybe in part because of aggressive pharmaceutical marketing of some of these testosterone replacement agents, I think there's a common misconception that testosterone replacement will make you feel younger again. And there are some improvements, as you saw from the data. There are some improvements in mood in men who have a low testosterone. There are some improvements in physical activity, but they weren't real big changes. And the fact is that our bodies get older, and there are a lot of changes that happen in our body not related to testosterone. And so replacing testosterone levels isn't going to make all of those things go away or go back to the way things were when you were 20. And in particular, I think there's a misconception about erectile function, and I see that a lot. Testosterone replacement in an older man with low testosterone rarely results in an effect on erectile function. To answer your second question about what questions you should be asking, I tried to answer it all in my talk, but you should be asking. I think what you should do is you should discuss this with your primary care physician if you have a concern about some of these symptoms. And I think you really need to have a one-on-one discussion with someone who knows you well about whether this could be affecting your quality of life or not, and whether the risks of testosterone replacement, if you have low testosterone, if you have symptoms of low testosterone, are worthwhile in your particular case. And that varies from person to person, but I think having that conversation with your primary care doc or asking for a referral to see an endocrinologist or a urologist who has experience with testosterone replacement is helpful. I was going to say something else, I forgot.
How significant is the connection between opioid use and low testosterone? And sort of at what levels does that become significant?
That's a great question. That's something that I'm interested in researching a little bit more because there isn't a whole lot of data out there, and a lot of it's pretty old. For example, Suboxone is a medication that's used to treat opioid addiction. It has an opioid component in it, but we really don't know much about how it affects men's testosterone levels, and a lot of young men who are taking this have fertility problems. We don't know a lot about how that's affecting it. We have very good data from a long time ago about methadone, and it's quite clear there's a very, very strong relationship between methadone use and low testosterone. And a lot of these men have pretty severe symptoms of low testosterone, and they respond very well to testosterone replacement in terms of energy and libido. And I think it's harder to do those studies with opioids that are being abused, heroin use, prescription opioids that are taken inappropriately. It's really hard to do research about that. Men taking those drugs because of a number of logistic issues. But it's likely that those opioids have an even more profound effect if used chronically on testosterone. Does that answer your question? It's a very tight association. It's quite clear, with the exception of Suboxone that we really don't know much about yet.
Would you say a little more about the diabetes connection? For example, when I was diagnosed with medication and exercise, at the same time, there was a dramatic drop in perhaps libido, but definitely the sex drive. So is it chicken and egg situation, or just what's going on?
That's a really good question, and something that I'm also interested in trying to learn more about, because I don't think we fully understand the relationship between metabolic syndrome, diabetes, and low testosterone, but we know they're very tightly associated. Is there something underlying the development of both conditions that is also causing, problems with energy, low libido, or is it the low testosterone that is leading to the development of metabolic syndrome, or is it diabetes that causes the testosterone to go down for some reason? We don't know the answer to that. We do know it's obviously important to treat the diabetes for a whole range of health reasons. But I think if the testosterone remains low and the symptoms persist, I think it's reasonable to replace the testosterone as well. Testosterone replacement in that situation might improve your motivation to go out and get the exercise that you need to help treat your diabetes. And the conditions are so tightly intertwined that it's really hard to separate things out. But I think the overall treatment plan needs to include the testosterone levels as well.
I think we could answer other questions offline, but I think
Yes.
Sarah wants to get us into the break, so we have a little time before the breakout session. Excellent talk.